So our next topic is actually a cage match debate, and I'm going to invite our three surgeon wrestlers to come and sit in the front, Dr. Madoff, Dr. Chang, and Dr. Sklow, please. The topic of the cage match is, what do we do after we have experienced a complete clinical response? What is the next step? Any of you guys who are familiar with cage matches, you know that those take place in a cage, and there's only three ways to end the match. One way is you can submit, and I don't expect any of those three gentlemen to submit. The second way is to pin your adversary to the floor. That is what I would expect. And the third way is to escape over the edge of this, and I'm hoping none of you chickens are going to do that. So each of those gentlemen will have 7 minutes to make a case, one after the other, and then there will be a 3-minute rebuttal. The first person in the cage is Dr. Madoff, who is going to talk about watch and wait.
So Judith has already put the fear of God into me that I don't go over my 7 minutes, so I'm going to try and be very careful. What I have to say about this, I've already said, so I'll just try and reiterate it in a slightly more leisurely fashion to make sure that it all can sink in. This actually was not Judith's slide. This is my slide, and this actually shows a young Bradford Sklow on the right back when in his Utah days. So I feel the disadvantage because I have no actual experience in the cage, and Brad has had it. Unfortunately, Brad got kind of an idiotic position he has to defend, so lots of luck. I'm still not quite sure how that topic got in here, and as a friend, I offer my sympathies, Brad, but I'm sure you do a good job. Okay, so for those of you who know me, I like the opera a lot, and this is actually a local thing. This is called a diva cage match right here in Minneapolis, and the sopranos try and sing themselves to death, or sing the other one to death. Why do we not do what George Chang is going to tell me that we have to do? Because having an anterior resection sucks. It doesn't suck as bad as having an abdominal perineal resection, but it still sucks. So even George is an elegant surgeon. Not everybody does things as well as he does, but even George, even Dave, anybody you pick, a small number of people die from their operations. A significant number have leaks, maybe or maybe not, they're consequential, but reoperations, functional problems, sexual and urinary, are a real thing, and they impact people's lives. And as I showed you before, bad low anterior resection syndrome is associated with bad quality of life. Now, you know, if you had to rush out of this room to get to the toilet and miss my talk in the cage match, that would not be the end of the world. But if you can't go out to dinner or watch a movie for fear that you're going to have an accident while you're eating, or you can't get down the row of things, it really interferes with your life. And the question that patients have to ask and surgeons have to ask themselves, is this trip really necessary? Is it worth it to pay this price to try and eliminate some risk that could be a phantom risk? And the issue of stoma, again, this comes in two versions. In a minority, it's a permanent colostomy. In the majority of people that have anterior resections, it's inevitable that you're going to have a temporary ileostomy. That's not that great. Not that great. The number one operation we do in our division, I think, is closing ileostomies because we put up so many of them. And patients don't enjoy it, for sure. Why not excise the scar? So this was the Z6041 trial, which was neoadjuvant chemoradiation followed by local excision. The results were actually reasonably good. It didn't focus on the patients. Half the patients actually had a pathologic complete response when they were excised. It doesn't really focus on that cohort at all. But one of the striking problems from the study was that there was this high rate of pelvic pain when you got excised after you've had chemoradiation. So I used to think the most reliable way you could temporarily destroy somebody's life was to do a hemorrhoidectomy because it hurts so much and patients are so miserable and they hate you so much. But in my limited experience with doing this, I got talked into doing this a number of years ago by a patient that really didn't want to have an anterior resection. He had the most profound, awful pain for months and months and months that was absolutely intractable to everything. It left a real impression on me. We sent him for hyperbaric oxygen. He was in pain clinic. He was on all kinds of meds. Local excisions after chemoradiation, most people don't have that problem, but the people that have it, they will never forget it, and they will never forget you. These are the data that I showed already, but I changed the slides. So on the left is the watch and wait database. On the right, these are patients that have nothing to do with watch and wait. These are patients that have had chemoradiation and went on to resection as part of the plan. And the red letters indicate that the red line are the patients that have had a pathologic complete response. And their curves do not look any better than people that have watch and wait. So you can look at overall survival or disease-free survival. Patients, even with complete responses following surgery, can still recur. So it's not like when you think about watch and wait, you think that, well, the alternative is I'll just have a major pelvic operation and my chances of recurrence will be 0. That ain't the case. And salvage surgery seems to be quite effective, and the big risk of salvage surgery that you're going to get to a place where you can't do the operation you were going to do before is a rare occurrence. You must track the patients, but the patient getting extremely badly burned and needing an exoneration, that's an exception rather than the rule. So all of the data show no differences in outcomes as far as we can tell. So I would end this just by saying that we're doctors. We have a way to do this that doesn't hurt patients quite as much. So let's remember, if we don't have to, let's not do any harm. Thanks very much.
Under 7 minutes. I'm impressed. Hop in the cage, Brad. Your turn. So Dr. Madoff gave you an N of 1 experience of why we should not do what you propose to do. Please defend your point.
Well, I don't have any financial disclosures, but I do have some other disclosures. The author of this presentation does not necessarily agree with this point of view presented. This topic was chosen for me by the organizers of the course, of which one was Dr. Madoff. And radical resection after chemoradiation for rectal cancer remains the gold standard in the United States. Now, I may have other motives for this talk. We know that Dr. Madoff comes from Boston. He's a Red Sox fan, and Dr. Chang is from Houston. He's probably an Astros fan, but I might have other alternatives for wanting to win this cage match. One of them is my dislike of the Red Sox, and the Houston Astros beat the Yankees, so let the challenge begin. We know that predictors of complete response, mucosal inspection, endoscopy, transrectal ultrasound, MRI, and CT scan are what people use after chemoradiation to see if there's a complete response. However, you'll see that it's not that great. This is a study from the Netherlands where 50 patients underwent chemoradiation followed by TME, TEM, or watch and wait. They used digital exam, endoscopy, and MRI to assess the response, of which they had 34% had a complete response. Sensitivity of MRI was only 35% to detect that response, and the clinical assessment was only 53%. And when all modalities indicated a residual tumor, 15% still had a complete response. And if you look at this study out of Korea, it's even worse. They had 124 patients with a 16% complete response, but all of their modalities, MRI, ultrasound, and mucosal inspection, only showed a 25% sensitivity to detect that complete response. If you took them all together, the results were even worse, anywhere from 0 to 10%. So we do a very poor job at telling who has had a complete response after chemoradiation. This is a very elegant study out of the Cleveland Clinic by Matt Kalady, where they actually looked at surgical specimens And then the pathology afterwards, they looked at what was left after chemoradiation. And if you look here, this ulcer and this ulcer, it looked like, well, there was tumor left. But in fact, there wasn't. 25% of patients had a YPT0 or a complete response, 25%. 74% of these patients had a residual mucosal abnormality, even though there was no tumor there. There were 40 residual ulcers, and 5 had exophytic lesions. So you couldn't tell that the tumor was completely gone because it looked like it was still there. The really disturbing thing is 27% with the scar that Dr. Madoff showed you in his presentation, that nothing was there, actually had residual disease. So there was no way to tell that everything was gone. Well, what about local excision after chemoradiation that Dr. Madoff said causes a lot of discomfort? This was a study where they had 44 patients from 94 to 06, full thickness excision after chemoradiation for T2 and T3 rectal cancers. The local recurrence rate was 9%, and the distant recurrence rate of 11%, and overall survival was 81% at 3 and 5 years, which mirrors what we know from radical resection. And they had 11% complication rate. Only one patient had suture breakdown with stenosis. And this is kind of a review of a bunch of studies that have been looked at local excision after chemoradiation with pretty good recurrence rates, anywhere from 0 to 12%. 12% is on the high, but that was a small series, and distant recurrence rates of 0 to 20%. If you look at the trials, and one of them Dr. Madoff mentioned, Julio's trial, the ACOSOG 6041, and if you look at them all together, local excision after chemoradiation, local recurrence rates were only 4 to 7%, with disease-free survival of 80 to 80%, which again mirrors radical resection. Well, if you look at all the data out there, at a systemic review of 20 studies, over 1,000 patients that underwent local excision after chemoradiation, the complete pathological response rate was 44%. For YPT0 tumors, so complete response pathologically after local excision, the local recurrence rate was only 4%, with a distant recurrence rate of 2.8%. Now, this is in 1,000 patients. Now, obviously, if you had a T1, T2, or T3 tumor left after chemoradiation, your results are much worse. So you could argue those patients should go on to radical resection. And they only had an incidence of morbidity of 23%, with a suture line dehiscence and pain as the most common, as Dr. Madoff mentioned. But that's far less morbidity than undergoing a radical resection, where you risk an anastomotic leak and all sorts of misery in the pelvis that you get when you do a big operation. So local excision after chemoradiation should be considered curative in patients who've had a complete pathological response in the local excision specimen. So to conclude, the current modalities to assess a complete pathological response are inadequate. You can't tell by MRI or digital exam that the tumor's gone. Local excision after neoadjuvant chemoradiation can be used to determine if there's been a complete pathological response. Patients who have a complete pathological response following chemoradiation have a high chance of cure. Radical surgery should be offered with an incomplete response because there is a high rate of local recurrence, as I showed you. And the only way to assess the accuracy of the response after neoadjuvant chemoradiation is by local excision, because our other modalities are not great. Thank you.
Dr. Chang will be addressing the tried and true.
I feel like I'm getting ganged up upon because we've got two people ganging up against radical resection. And so I kind of feel like I should be given an extra credit point just because of that.
I feel like I have two people ganging up against watching work.
All right, so this is what we're talking about, right? This is the dilemma. This is the subject of the debate. These two patients, 10 to 12 weeks after chemoradiation therapy, what's going on with them? Well, we have a couple. So since I knew I was going to be doing a debate, I wanted to look up with whom am I doing the debate? And so I found this picture of Professor Rob Madoff. Might have been 10 years ago or 15 years ago, I think, this photo. And of course, this kind of suspicious-looking guy. So I wanted to learn a little bit more about him. And I realized that one of them is going to try to, give us some, Ponzi scheme idea about how he's got the greatest, best, latest, most awesomest thing to do. And the other dude, I found him on Instagram. He's an influencer. Do you see that? 149,000 followers. And look at his job. He's a collagen salesman. And he just started out telling us that his disclaimer was he didn't necessarily believe in what he was selling us. So multidisciplinary management of rectal cancer works. We know that that radiotherapy plus surgery provides excellent control, and we know that we can get complete responses in some patients. So what is the association between treatment response and outcome? So we've seen some of this data. We know that patients who respond do well, but let's look a little bit more closely, and this is data from MD Anderson, where we looked at patients who had a pathologic complete response in blue, a intermediate response in gold, and poor response in gray. And what happens if you operate on these patients? Well, there are 0 local failures if you operate on these patients. Just remember that number, 0. There are a total of 6% distant failure. So these patients do really well. Like, these numbers look better than those local excision numbers for T1 disease that I was talking about earlier. I mean, these patients can be cured and fixed of their ailment by chemoradiation, by surgery to follow chemoradiation. The other thing we know that treatment response improves sphincter preservation, and so this concept of, oh, well, they're going to need an APR, well, that's not necessarily always true either. And so then the debate here is, well, if these patients if we can't see tumor, we shouldn't operate on them. Well, what actually happens? Now, I'm going to preface this by saying that, there's a number of systematic reviews we can always look at about things, particularly new things. There's a tremendous publication bias that goes into it. So Rob showed us, and I'm going to show us some other data. Rob was pointing out one systematic review. It happens to be the one that shows the lowest regrowth rate because people only publish their good data. But when we look carefully at the data from the Encore registry, we can see that the regrowth rate is 38%. So not 0%, but 38% of the patients will now have tumor again if you don't operate on them. And in fact, in the watch and wait registry, it was 1 out of 4. So that's quite a few patients who are going to be sitting there biting their nails because, am I going to get a recurrence? Am I going to get a recurrence? And in fact, we did a systematic review, and we identified an overall regrowth rate of 21% in what I would argue is still a fairly biased set of literature. So what about these patients I showed you earlier? What do you think these patients, can I have a vote? Like, raise your hand. Complete response on the left? Like, okay. And how about on the right? Complete response? I'll take those who don't raise their hand to say, okay. So these were actual real patients of mine, and the patient on the left said, I want an operation. And because he actually was offered a coloanal, but he said, you know what, I want an APR. I said, fine, so we did the APR. And on the right, he says, you know what, I want to help you guys learn. Let's not operate on me. The guy on the left, T1N1. The guy on the right regrew at 13 months. So neither of them had a complete response. All right, what about the unexamined mesorectum? Because Dr. Sklow, the collagen salesman influencer guy, says, well, we need to just know what's going on in the bowel wall. So we know what's going on in the bowel wall. So when we looked at our experience of YPT0, we see even among YPT0 patients, there's a 9% risk of lymph node metastasis within the unresected, which would be in the unresected mesorectum. And you can see that rate goes up. And that's just those guys at MD Anderson. They don't know what they're doing, or they're operating too soon, or they only see those special patients. Well, on the right is the data from the German rectal cancer trial. And you can see, what is that? 8.8%. We round that up, 9. Looks just like our data. And that's randomized data from an unselected patient population. So the unexamined mesorectum is important. What about, well, we can salvage everybody, right? We can salvage them. Well, this is actually Angelita Habergama's data. And if you actually go through all of the math, you can see that an R0 salvage rate is achieved in 89% of the patients. So 11% of the patients never got to R0 salvage. And what did we say? Local recurrence was what if we operate on those patients? 0. and distant failure, 6%. Neither of those numbers are as large as 11%. And what about, this is actually, I really like Andrew Renahan's study because this is sort of very pragmatic. This is very real world data. Salvage rate in the real world, not at a center where they have been doing watch and wait for a really long time, and actually people flock there to get watch and wait, and a lot of patients who have perhaps earlier disease are included in that strategy. If we take kind of a more all-comer strategy, 72%, only 72% can be salvaged. And most of the time when they get salvaged, they get a colostomy. Well, when we operate initially, we often can offer a coloanal, and so now we're committing patients who could get a coloanal to a colostomy by the time that they regrow. And Rob showed these same graphs, but I would interpret them a little bit differently, because only 26% actually avoided a colostomy. So he makes it seem like tons of people avoided a colostomy. Actually, only 1 in 4 patients actually avoided a colostomy, so the impact may not be as great as you think. And the long-term outcomes without TME, well, so this is data actually from Memorial Sloan Kettering that was recently published. But what I want to show is so they have a regrowth rate of 20-some-odd%, but on the right, when patients regrow, look at the watch and wait cohort and their disease-free survival. And when they regrow, the distant metastasis rate was 31% versus 1% in those patients who did not. And so, is it ready for prime? Why is it not ready for prime time? Because we don't have comparable outcomes. Actually, we don't really know well. We can't predict response. Can we identify selection criteria? No. Do we know when we should evaluate? No. Do we know a surveillance strategy that works best? No. And do we know if salvage surgery is possible? No. Dr. Madoff said that it's prime time, but I'm not sure what about it is really ready for prime time. Thank you.
The glove has been sent. Dr. Madoff, 3 minutes.
Bah. Humbug. I don't have any slides for this part, and just a few comments. So for poor Dr. Sklow, you were hosed, but the issue is actually, it's not about if you can definitively tell if there's residual tumor or not. I think the argument is we know that we're imperfect at this. We have to accept that. But you get to do multiple observations. You get to see if there is something that's there, if there is an occult node in the mesorectum, if there is occult tumor in the surface of the bowel that we don't see in the scar, we don't see in the MRI, you're going to be looking at it again in a couple of months, and a couple of months after that. And I think the big issue about that is that it appears that repeated observation, close observation, you don't lose the opportunity to do things. George, made a big deal about the Onacor data. He just didn't read the conclusions of their paper. Or he probably read them, but he didn't share them with you. They concluded that they thought watch and wait was a good thing to do and that they were going to continue doing it. That's the conclusion of that paper, George Chang. For Brad, the other thing is that I accept that if you give neoadjuvant therapy and you do a local excision, you can get very good results. But that's not the question here. The question is, if you have what looks like a healed scar, what's the benefit of locally excising a healed scar? Does that actually prevent pelvic or distant recurrence? I don't think so. I'll see it could prevent if there's actually tumor there. If you see some tumor there, maybe that will reduce the local recurrence rate. I'll cede that point. But you'll know about that local recurrence if it happens. If you just wait, you don't have to do it. And I do think the downside. Judith says it's my N=1 experience, but the literature, the paper I showed 15%, the paper Brad showed was 25%. It's a real thing, and it's really horrible. George, nobody has a 0 recurrence rate for anything. That's how it is. There are plenty of data which I've shown, that if you have a pathologic complete response, it's a very favorable group, but they still recur, even when you put them through all the rigmarole that George wants to. Be strong, my friends. Stay with me. Go Sox. And the Astros cheat.
Well, you've already heard about the regrowth rate from Dr. Madoff, 16 to 25%, as high as 38%, according to some of the data George showed. And I think that's because you don't know what's in the scar. And when it looks like it's not gone, it might be gone. So I think Dr. Madoff has his head in the clouds a little bit, is ignoring the high regrowth rates. And George might be trying to kill a fly with a shotgun with his approach. And he is from Texas. So if you look at this study by John Marks from Philadelphia, who had 43 patients with neoadjuvant chemoradiation by TEM compared with radiation followed by TEM alone, so half the group didn't have radiation. Granted, the morbidity was higher in the radiated group. 82% of it were wound complications, but 91% of them were minor and were treated without any other intervention. So the conclusion was that wound complications do not prohibit TEM after neoadjuvant treatment, to go to Dr. Madoff's point. Now, if you look at this study, published by Dr. Chang from MD Anderson, that looked at lymph node metastases after chemoradiation. This was in the pre-total neoadjuvant therapy era, 99 to 03, pre-TNT. And if you look at this, the local recurrence rate was 0 for YPT0, but it was only 7% even with positive lymph nodes. So local recurrence rate was still fairly low, even if you had a positive lymph node, if there was no primary tumor there. And lo and behold, no survival difference in whether or not you had a positive node if the primary was gone versus no positive nodes. Now, this study also came out of MD Anderson, and this compared TME to local excision. But if you look here, who's absent from this article? George is not one of the authors. And all of these tumors were T3N0, T3N1. They underwent chemoradiation. And they compared the local excision group, who refused a radical resection or were not good candidates, to the TME group. Median follow-up is 5 years. And lo and behold, same local recurrence rate and same survival in both groups. So it might be like killing a fly with a shotgun, and maybe we're operating on too many patients. But this trial might answer some of that. This is a non-inferiority, multi-center prospective trial that's been proposed in Spain of rectal cancer, T2 and T3 tumors undergoing neoadjuvant treatment and local excision versus TME. And this might answer some of those questions. Can we get similar results in a prospective randomized way? And only time will tell. But I would argue you don't know what's in the scar. And maybe we can improve our results of regrowth, these high regrowth rates, by excising the scar rather than just watching and waiting. So I'm hoping that maybe they got my opinion, but I doubt it. Thank you.
Judith presented a slide in the beginning that showed that cage match with that guy with that, like the thing that goes up the leg with all the spikes in it. And I don't know if you picked up on it, but that same picture was in one of Rob Madoff's slides. This is rigged. Oh, well, it's still rigged. All right. So I got a little bit more. I got a little bit more information. And I realized now why we've been hearing such elegant arguments, because, I don't know, I found this little article here. This is a blogger who's talking about blogging about bending over. And it was the very famous colon and rectal surgeon, Dr. Bradford Sklow. So maybe he's not that Instagrammer that I found earlier. I also found this great evidence-based update for primary care providers, published actually quite recently. Wolf was the first author. And in this paper, there's Dr. Madoff's picture right there, he says, currently radical resection with TME remains the standard curative operation for rectal cancer. And it says these data about the Haber-Gamma data should be received with caution, because others have shown that greater than 80% of complete clinical responders will recur locally within the first 10 months of observation. So I think this is a Ponzi scheme, because he's talking about things like, he's talking both ways. And this is a very recent publication, like 2015. So he'll have us believe that watch and wait avoids severe LARS. More than 1 in 3 patients who undergo chemoradiation for rectal cancer and have an intact rectum still have severe LARS. So it's not the panacea that we think it is. And Dr. Sklow would say that, it's no big deal to do local excision. And I ran out of space to talk about all the papers, and this was particularly scary because this was actually a prospective trial that had to close after only 14 patients were enrolled because they were getting problems like that. That actually is like behind the sacrum. The anus is over here. And even local excision gets LARS. But what's really important, I want to point out, is when we don't do the definitive procedure, look how much anxiety there exists. Here is the anxiety with TEM versus anxiety with an operation. And so when we don't do the definitive operation for these patients, people are nervous. And so do we want to subject our patients to that kind of nerve-wracking anxiety by simply leaving their disease intact? So I think that a lot of people have agreed with my position. You simply have to count the number of clinical trials that are out there trying to test the question. That is, we are still doing radical resection because we don't know that it's good enough not to, and simply by counting the number of trials, we can see the overwhelming agreement. So I'm going to end with a cautionary tale. So this is a patient who presented in May of 2017 with this tumor. Doesn't look too bad, and so gets chemoradiated and looks like this. It's an MRTRG0 and what looks like a clinical complete response. And Dr. Madoff says we'll know about it soon, because in a couple months we'll know. He sure did, because this is 3 months later, and now the tumor is invading the prostate gland. This patient needed an exenteration. The final pass showed a T4B ulcerated tumor, now 4 centimeters in size, and this is perhaps a patient who could have avoided this up front. Thank you.
Thank you, gentlemen. I would like to hear from the people in the audience. If you had a rectal cancer and you had complete clinical response, by show of hands, who would pick to watch and wait? Who would pick to have a local excision? Who would pick to have a standard TME? Thank you, gentlemen. Very much appreciated.